Witam wszystkich koleżanki, kolegów i gości. Przede wszystkim naszego gościa dzisiaj, legenda, dr Joannę Lukawską, która jest konsultantem alergologiem w University College Hospital. Bardzo się cieszymy, że znalazła tą chwilę czasu. Chociaż teraz przed świętami i w ogóle wszyscy są zajęci, ale tak się cieszymy, bo temat jest bardzo aktualny i naprawdę jest z wielką ciekawością czekamy. No i serdecznie zapraszam. Mateusz, to proszę może teraz zrób tak, żeby było pani doktor twarz na dużą, a my wszyscy na schowane.
Okej, oczywiście. Pani doktor, tak jak się umawialiśmy, ma pani możliwość udostępnienia swojego ekranu, także przekazuję głos pani.
Czyli mogę przełączyć na share screen, tak? Panie Mateuszu, tak?
Tak.
Tak, oczywiście.
Dobry wieczór Państwu. Bardzo dziękuję za zaproszenie i obiecuję, że się przyłączę do Państwa stowarzyszenia. Bardzo mi się u Was podoba, chociaż remotely. Będę mówić po angielsku, jeżeli to jest w porządku. Więc so I would like to talk about vaccinating allergic patients with COVID-19 vaccination. My name is Joanna Lukawska. As Dr. Joanna said, I work at UCLH. I'm a consultant in adult allergy medicine. And 9th of December 2020 was like, for the allergists, was like, I think 9/11 for everyone else, because I will never forget what I was doing. I was in the middle of a day unit work at UCLH, and we normally have the radio on. What we do on the day unit in allergy, we challenge patients to drugs we believe patients may or may not be allergic, and we were in the middle of our work. We had the radio on, and the news of 2 health workers having serious anaphylactic reactions to Pfizer BioNTech COVID-19 vaccination came out. And at that very moment, we knew that our lives in clinical allergy would not be the same for the foreseeable future. We expected that with the new vaccinations, there would be more referrals and more questions. We knew that because we have regular referrals for people who have allergic reactions to influenza vaccination or MMR or rabies or tetanus, but we had no idea what was coming. So you will remember that 2 healthcare workers had, following the first dose of Pfizer vaccination, suffered anaphylaxis. One of them was a lady in her 40s, and she had a history of allergy to drugs. The other one was also middle-aged, and she had history of food allergy. And MHRA was quick on their heels. They immediately issued this advice, which read as follows, that individuals with a history of anaphylaxis to any vaccine, medicine or food should not receive the vaccination. So that's the COVID-19 vaccination. This started an amazing furore because 1/3 of the population is allergic to something. The patients with food allergy, bee and wasp sting allergies, drug allergies were all turned back, were all turned away from the mass vaccination centers. On the 30th of December, new advice appeared, which allowed with allergic reactions to food and other aero allergens. Oh, because of course, even people with hay fever were being turned away from vaccination centers. So they updated guideline from MHRA suggested that only patients with allergic reactions to the actual vaccine ingredients or patients who suffered anaphylaxis to the first dose should not receive Pfizer BioNTech COVID-19 vaccination. But by then it was too late, because what we received is letters, queries, emails, you name it, which flooded our offices and our inboxes. So this is an example, an 82-year-old lady. She's been shielding for a year. She has known contrast agent anaphylaxis, and she's been trying to get vaccinated. Unfortunately, again, she's been turned away from everywhere. She's contacted MHRA, and the advice she received, she described as ambiguous and non-committal. So a step back, what is anaphylaxis? And I know that you all know what anaphylaxis would look like, but the definition is actually very tricky. So here is a selection of my favorite ones. So severe, life-threatening, generalized or systemic hypersensitivity reaction, that's from EACI, European Academy of Allergy and Clinical Immunology. We are discouraged from using the term anaphylactoid. Since 2001, that has been removed from our dictionary in allergy. There is another one that I like from Food Allergy and Anaphylaxis Network, which states anaphylaxis is a serious allergic reaction that is rapid in onset and may lead to death. However, my absolute favorite one is this. Anaphylaxis is hard to define, but I know it when I see it. This comes from Jackie from Journal of Allergy and Clinical Immunology. It's an allergist definition. And it is hard to define, and you need to see it a few times before you can confidently make that diagnosis. Now, the rate of anaphylaxis with vaccination generally is very low. It's about 1.31 cases in a million. So that's with influenza vaccination, even yellow fever, typhoid. The average rate of anaphylaxis is 1.31 in a million. Some more stats about anaphylaxis. So 5 in every 100 of us during our lifetime will have at least one episode of anaphylaxis, but only 1% of cases of anaphylaxis are fatal. 60% of deaths from anaphylaxis are due to drugs, and most of these deaths, around 90%, occur in hospital. And the reason for it is because most of deaths are due to anaphylaxis from drugs, and in hospital, what do? We give drugs fast and through the IV route, which is far more potent at inducing anaphylaxis than by mouth or stuff out. So after antibiotics, because antibiotics are still the main leading cause of anaphylaxis, contrast agents are the second most common drug inducing anaphylaxis in patients. Vaccinations don't even make it into the list of the top 5. A bit more about anaphylaxis, and I'm not sure you can see the picture because there is a lovely picture. Is it possible to show these photographs?
We see the pictures, yes.
You do? Okay, excellent. It's only I could tell. So the other problem with anaphylaxis, we've already said, it's poorly defined. There is no bedside test, so you can't just stand by a patient in the middle of anaphylaxis and order a test. You can order tryptase post hoc once the patient is stable. Tryptase is a measure of mast cell degranulation, and it will give you an indication, but even if tryptase is negative, patient may have had an anaphylactic event, so it's not diagnostic. There is a spectrum of severity, and that's a really difficult one because Sometimes anaphylaxis will present as a runny nose and itchy throat and urticaria on your legs, and it will not progress any further than that. Next time, and some you may wish to describe it as a systemic allergic reaction. On another occasion, in the very same patient, these symptoms may progress to cardiac arrest. The third problem, and we've touched on it, is that there is low morbidity and low mortality. Why is that a problem? So low morbidity, most patients who recover from anaphylaxis have there is no detriment to their long-term health. Low mortality means that it doesn't really attract the attention, other than, I think, once every couple of years when a young person dies from food allergy, or there is an inadvertent exposure in hospital to the drug that the patient was allergic to and the patient dies. It's not a hot topic in medicine. And the final problem is reproducibility of reactions, and hence my pictures. So I had got this patient's permission to use them. So this is a young female who presented to the general allergy clinic with 2 episodes of swelling, and she's taken a photograph of the top one, so you can see just below her neckline she's got a swelling, which is angioedema, and this was closely associated with beating muscles. So she came to our day unit, and I've already partially described what we do there. We challenge patients to confirm that they are allergic to what we think they are allergic. The skin test, you may say, why would you bother doing that? Well, can't you just skin test them? Skin tests are good, but they're not 100%. So they work 60 to 80% of the time. So she skin tested negative. We fed her, I think, 2 mussels, and what she developed is that very unimpressive skin rash you can see below, which if you could focus closely, you would see that it's got like an urticarial wheal in the middle. But what came as a surprise is that she became very wheezy and short of breath at the same time, and she was treated with adrenaline. So what I'm trying to say is that her initial presentation was just of that angioedema, that strange looking swelling, which she presented with. But on the subsequent occasion, and we actually witnessed it, it was shortness of breath, dyspnea, wheeze, and urticarial skin rash. So, and there is another confounding factor. You know how I said that the patients with anaphylaxis can present with symptoms of urticaria and angioedema. Urticaria is a bumpy, itchy, red skin rash. Angioedema is a swelling. They're part of the same pathology, basically fluid leaking out of blood vessels and leading to swelling. When it's very superficial, it presents as urticaria, here. And when it's a bit deeper, in the deeper layers of the dermis, it presents as angioedema. These can be symptoms of allergic reaction. However, there is also a condition called spontaneous urticaria and angioedema. The other term for it is idiopathic urticaria and angioedema, which has nothing to do with allergic reactions. It's a completely benign, very common condition which occurs in 1 in every 5 of us during our lifetime. It leads to these symptoms of swelling, itchy skin, but they are not provoked by allergic reaction. It's usually self-limiting. It very rarely leads to the need to see the patient in the hospital. Some patients do present to A&E, but it's usually with stress reaction associated with this unusual looking skin rash or swelling. And it can be exacerbated by stress. So, and it's not just psychological stress, a biological stress of an infection, physiological stress of exercise, heat, certain drugs such as non-steroidal anti-inflammatory drugs, alcohol. And we can treat it very effectively with second generation non-sedating antihistamines such as cetirizine, loratadine, or we prefer fexofenadine at a good dose of 180 milligrams up to 4 times a day. And the treatment failure usually lies in the fact that the patients are not getting a high enough dose of antihistamine. So back to Pfizer. So remember the furore with the first few reactions to Pfizer, first in the UK, then in the United States. And the incidence of anaphylaxis has been estimated to be around 1 in 200 injections. So that's the anaphylaxis to Pfizer-BioNTech. And as you know, you can be allergic when you're allergic to vaccination, you are allergic either to the active component, which is the mRNA in the vaccination, or to the excipients. And here we've got a lovely list of a long list of excipients. And when you look closely at it, you'll see that there is one of these excipients is polyethylene glycol. And when the news of Pfizer using, this is before the vaccine was even introduced to the market, the news of Pfizer using PEG, polyethylene glycol, reached the allergy community. We were all a little bit worried about this because polyethylene glycol is a tricky allergen to deal with, and I'll tell you a little bit more about it in a minute. So what about these cases of anaphylaxis to Pfizer-BioNTech? We don't have the UK data yet. I know that the data is there, it's just awaiting publication and it cannot be shared, but we have got the American data. So the rate of anaphylaxis appears a little bit higher, but this may be because it's due to the Webb effect. I don't know if you know about this strange phenomenon that when you first introduce a medication or a procedure, and you try to assess problems with it, apparently more problems get reported, and it all with time, it all evens out. I don't know, but this data comes from JAMA, and it was collected by Shima Bukuro et al, and they looked at the cases reported cases of anaphylaxis. They then assessed them according to known criteria, and what they found is that they could actually confirm 21 cases who did have anaphylaxis following their first dose of Pfizer-BioNTech. So the median onset of symptoms was 13 minutes, but it ranged between 2 minutes to 150 minutes, so just over 2 hours. 86% of the patients developed symptoms of anaphylaxis within the first 30 minutes. 81 of them had known allergy to either drugs, medical problems, food or insect stings. The most common initial symptoms were urticaria, angioedema, and the sense of throat closure. 33% had history of previous anaphylaxis. So interestingly, one of these was a case of anaphylaxis to rabies vaccine. Another was a case of anaphylaxis to influenza vaccine. And 3 patients needed treatment in ITU. No patients died. Okay, so what about AstraZeneca? The rate of anaphylaxis with AstraZeneca seems a little bit lower. It's 1 in a million. However, I saw a report from EMA, so European Medicines Agency, which which actually the report stated that EMA assessed the rate of anaphylaxis to be much higher than 1 in a million. Now, I couldn't actually find the report itself, so I'm not quoting it here. These are the excipients. So again, we've got a virus, we've got a chimpanzee proliferation deficient virus, which is encoded for the spike protein, and that's the active ingredient. And then we have all the excipients similar, but not quite to Pfizer. So the interesting potentially allergenic excipient in AstraZeneca is polysorbate 80. And finally, Moderna. Not quite here yet. We expect to start using Moderna in April. The rate of anaphylaxis is that of 1 in 360,000. It's slightly less so than Pfizer. And again, it's another mRNA vaccination, hence it needs lipids. It needs to be, for the mRNA to be protected from the initial insult of the immune system. And that's why it's encoded in these, it's not encoded, it's enclosed in these lipids. And you'll notice that one of them is, of course, PEG. It also contains another potential allergen, that's trometamol, tromethamine. We at UCLH actually reported a case of a young female who a couple of years ago had a nasty anaphylaxis following a gallium MRI scan. And she wasn't allergic to gallium. She was actually allergic to the excipient within gallium. So that's another potential source of allergic reactions. So back to polyethylene glycol. So polyethylene glycol, we said it's an excipient both in Pfizer BioNTech, but also in Moderna, so an important excipient. It's derived from petroleum. It's got multitude of names, and I haven't listed them all here. The most commonly used name is PEG, PEG, carbowax, ethylene glycol, ethylene oxide polymer, and macrogol. You may know it as macrogol. PEG has very challenging nomenclature. So if you look at the ingredients in your cosmetics, you will very often find PEG mentioned there, and you will find a number attached to it. So, for example, PEG 75, and in the cosmetic industry, the number 75, it implies that there are 75 ethylene glycol units, so 75 discrete units attached into a chain. Each ethylene oxide unit has a molecular weight of about 44, and what happens when the same PEG is used by pharmaceutical industry, they multiply the number of units, the number of ethylene oxide units by the molecular weight, and the number that is listed in the list of ingredients is then the result of is approximation of that multiplication. So you will see in Movicol the PEG used is 3,350, but it is the same PEG 75 used in other products. So one has to be super careful. It's very unclear which PEG you're actually dealing with. The other thing to mention is that PEG, low molecular weight PEGs are clear, viscous, water-like. The higher the molecular weight, the more opaque the product becomes, and a PEG of over 10,000 becomes a solid. Now, why does it matter, molecular weight, the number? It matters because some patients will be allergic to all PEGs, very high molecular weight, and the others will only be allergic to certain molecular weight unit preparation, so usually the higher one. So they might be allergic to products with PEG over 6,000, but they would tolerate Movicol, which has PEG 3,350. Where is PEG used? So I've already mentioned Movicol is a prime example. It's pure PEG, nothing else. It's used in laxatives and bowel prep. It's used as a pill binder, tablet coating, parenteral liquid preparations, in gels and lubricants, wound dressings, and in pegylated drugs. So again, the reason, for the same reason as it is used in Pfizer and in Moderna, to basically increase the circulation time, but mostly to prevent the actual agent from the immune system opsonization. So the best example here is amphotericin as ambizone. Ambizone is pegylated amphotericin. And of course, PEG is plenty of PEG in cosmetics, in shampoo, hair dyes, lipsticks, and shaving creams. Okay, so you may or may not be aware of this case. This is a case of a unfortunate 53-year-old father of four who worked as a builder. And in 2002, he developed skin rash following his surgery. He then at some stage had a reaction to mushroom powder. In 2009, he had another reaction to gravy. In 2010, he unfortunately broke his leg and had surgery. Following the surgery, he was labeled with allergy to metal plate in his leg. In 2012, he had a root canal treatment and again had an allergic reaction. And after this, he became labeled, he was labeled with local anesthetic allergy. A year later, 2013, he drank an orange drink and developed itchy skin and he blacked out. In April 2014, in the local hospital, he received a steroid injection into his lower leg, and this led to the immediate appearance of red lumps, urticaria. He was labeled as query steroid allergy. Now, this prompted a referral to an immunologist who did actually do due diligence and diagnosed PEG allergy. But unfortunately, in July 2015, he had another steroid injection and developed immediate anaphylaxis, which led to a multi-organ failure, and he died. So what went wrong here? So father of four, 2001, he had skin rash following surgery, likely to betadine and betadine and possibly a PEG polyethylene glycol in his wound dressing. Reaction to mushroom powder, we're not sure about this one. There are two products that are potentially cross-reactive with PEG, which are used in food. One is polysorbate 80, the other one is propylene glycol. He then had another reaction to 2009, again, possibly propylene glycol. 2010, leg surgery. You remember he was labeled as allergic to metal plate in his leg, exceedingly unlikely. He probably had either allergic reaction to betadine again or the wound dressing. The hydrogels in the wound dressing contain a lot of PEG. In 2012, he has a root canal treatment. And what happens when you have a root canal treatment? Of course, you get a local anesthetic, but you also get gutta-percha inside your tooth, closely exposed to the open wound. And a gutta-percha contains, it's a rubbery substance, which is sealed with polyethylene glycol. He then, 2013, he has a blackout following an orange drink. The orange drink may or may not have been, again, food, but it could have been Laxido orange or Movicol orange. And then 2014, the leg injection, he was injected with steroid containing PEG, and unfortunate event in 2015, in spite of the diagnosis of PEG allergy being made, And in spite of somebody querying steroid allergy, of course he was never allergic to steroid. It was just the PEG interferon that he reacted to. And an inquest followed his death. And this is an interesting statement from the immunologist who was in charge of his case, who did diagnose PEG allergy. So I'll credit where credit is due. But the statement read, "We had a very unusual situation here with a person who appears to be reacting to some polyethylene glycols, sometimes reacting to, sometimes not reacting." And remember what I said about this strange thing with the molecular weight, where you have a patient who may be allergic to the whole range of PEGs. And then you have a patient who will be allergic to just some PEGs, usually the higher molecular weight PEGs. So there will be a threshold when they will start reacting. They'll be able to tolerate a PEG of 4,000, 2,000, 1,400, but once that number, say, reaches 6,000, they will have anaphylaxis. Okay, so that's PEG in Pfizer and in Moderna. What about potential allergen in AstraZeneca? So AstraZeneca contains polysorbate 80. Polysorbate 80 is otherwise known as twin 80 or polyoxyethylene sorbitol monooleate. It's used as a surfactant in food, in ice cream, gelatin, desserts, barbecue sauce products. It's used in cosmetics. So if you use Dove Silk body cream, you slather it all over you. Vichy's low age eye contour cream. It's used a lot in pharmaceuticals. So there are about 30 pages on EMC, the Medicines Compendium, devoted to polysorbate 80. It's used so frequently because it's a useful product. It allows us to suspend medication in liquids. And in vaccines in particular, it's an emulsifier. So it disperses all the ingredients evenly in the liquid. So is polysorbate allergy real? Yes, absolutely. There are cases described in literature. Why don't we know more about it? Because we don't often look for it. We don't have enough allergists to do the job, and there aren't enough drug allergy centers to diagnose it. So a few cases, papilloma virus vaccination, Gardasil, because not all papilloma virus vaccinations contain polysorbate 80. So this is a case of a 17-year-old girl who had generalized urticaria, angioedema, rhinitis, and conjunctivitis, and wheezing 1 hour after her third intramuscular administration of quadrivalent human papillomavirus vaccine. She was very well investigated by the allergy team who looked after her and who diagnosed a polysorbate 80 allergy. Omalizumab. Omalizumab is an anti-IgE monoclonal antibody. We use it in asthma, and we also use it in treatment-resistant spontaneous urticaria, so urticaria that does not respond to fexofenadine or cetirizine 4 times a day. So there are 2 cases of asthmatic patients who were treated with omalizumab for a while and then developed anaphylaxis, and again they were investigated, and polysorbate 80 allergy was confirmed. There is a case of a 15-year-old girl who developed dyspnea and wheezing after the first dose of omalizumab. And then there is a very interesting case of a 31-year-old female who was treated with mepolizumab for her asthma, and then on her 13th injection, so she's tolerated the first 10, 11, 12. She probably, my guess would have been that she probably started having symptoms on a bit earlier, but perhaps didn't share them, or not much was made of them. But Nonetheless, on the 13th injection of her mepolizumab, she developed dyspnea, wheeze, low blood pressure, raised pulse rate. So all the symptoms, all the signs and symptoms of anaphylaxis. Now, she was then switched from the diagnosis of mepolizumab allergy was made, and she was switched from mepolizumab to omalizumab, which of course contains polysorbate, and she had the same symptoms. Now this woman was tested and proved to be allergic to polysorbate. So okay, here is the essence of this presentation, I hope. And this is a pathway for patients who have allergies and present for their first vaccination. Now, pretty straightforward to follow. The pathway actually comes from the Green Book of the COVID vaccination, and what we see here is that the green pathway is very easy. So patients who have allergic reactions, even anaphylaxis to food, so well-defined food, insect sting, most medicines, where there is confidence that the trigger is the drug or an identified excipient. So this is, for example, somebody who has allergy, anaphylaxis to penicillin, who doesn't react to any other drugs. You are confident that the antigen, the allergen, is penicillin itself. It's not an excipient, it's clear. They had, say on the first exposure, they had urticaria, then they made a mistake and took it again 6 months later, and they had urticaria, angioedema, and vomiting. So these patients, as well as patients with family history of allergy, patients who had previous local allergic reaction to a vaccination. By local allergic reaction, we mean just a reaction of redness and perhaps swelling at the injection site of the vaccination. Patients with well-defined allergy to non-steroidal anti-inflammatory drugs such as aspirin and ibuprofen, or patients with mastocytosis. All these patients can receive vaccination, and any type of vaccination, Pfizer, Moderna, or AstraZeneca, anywhere. So in mass vaccination centers, in the hospital, it doesn't matter. Now the problem starts here. This is the yellow box, the precaution box, and you will see that what this box is getting at specifically, and this pathway is designed by us for UCLH, and we're trying to explain the Green Book to our community, to our GPs, and to and in particular to people who work in the mass vaccination centers. So these are the tricky patients who have a history of immediate anaphylaxis to multiple drugs from different families. So they may be, there may be beta-lactam, but penicillin, but there will also be doxycycline, there will also be celecoxib, or there will also be malaria, Malaron drug. So that you can't explain, because in general, multiple drug allergy is very uncommon. It's very uncommon to develop allergy to different groups of drugs. And if you see that, it's likely that there is some common ingredients that these patients are reacting to. So here we're getting at, is the patient allergic to PEG, or are they allergic to a polysorbate 80? In particular, history of anaphylaxis to vaccines or injected monoclonal antibodies. A lot of vaccines will have polysorbate. A lot of monoclonal antibodies will have polysorbate. Depots, steroid injections, of course, polyethylene glycol, and laxatives, again, polyethylene glycol. And people with history of idiopathic anaphylaxis. Why idiopathic anaphylaxis, and what is idiopathic anaphylaxis? Idiopathic anaphylaxis is anaphylaxis that we have not been able to establish a cause of. And because there are so few allergy centers and there are so few, even fewer drug allergy centers, these patients, there is a fear that these patients may not have been investigated, that there actually could be a trigger, but that the trigger has not been established. So if you had somebody who's truly got idiopathic anaphylaxis unprovoked, then the situation is different. But the implication is that this patient might not have seen an allergist, they might not have been investigated, and they might still have PEG or polysorbate or trometamol allergy. And these patients not to receive Pfizer or Moderna. Now I've put a box over what to do with them next, because the Green Book will tell you that if the patient is allergic to, you can prove, if you can prove that the patient, since the index reaction, so since the time when they had the anaphylactic event, have received a flu vaccination. If you can prove that the flu vaccination contained polysorbate 80, because over 60% of flu vaccines contain polysorbate 80, then you can safely tell this patient to be vaccinated with AstraZeneca, which has polysorbate 80 in the community. But this is a very tricky job. It's very difficult to do it because the patient themselves won't know, even if they have received a vaccination, they won't know what type of vaccination. And it will, and occasionally, a lot of the vaccinations are done, of course, by GPs, by family practitioners, but some of them are done in the pharmacy. And it does need a little bit of it needs a little bit of working out. It needs somebody to obtain the records. We here at UCLH, we hope to get the help of our pharmacists to do that, but we haven't got this part of the pathway quite established yet, hence it's been blacked out. And finally, we come to the yellow, to the red box, which is basically don't vaccinate, refer the patient to the hospital hub to see an allergist. And here are patients who had a systemic allergic reaction to the first dose, that's clear, and patients who have previously been labeled as allergic to either a polysorbate 80 or PEG. So what about patients? So this was what to do, how to follow the pathway for the first dose. How about the second dose? So here is our UCLH diagram, and most centers will have something very similar of what to do with the second doses. So hopefully most patients will have no reaction, and then they can safely receive their second dose. For people who had a non-allergic reaction following the first vaccination, so by this we mean vasovagal episodes and non-urticarial skin rashes, so a bit of erythema, non-specific skin rash, we advise that they get vaccinated in the either mass vaccination center or wherever they were vaccinated first done. Now, for people who did have a reaction following the first dose, we make a distinction between the timings of the reaction. So if the vaccination occurred within the first 2 hours, and the 2 hours is a compromise, because remember the Pfizer paper I told you about from JAMA that stated that the majority of the reactions happened within, so I think 86% happened within the first 30 minutes, but there was one case that occurred at 150 minutes. So the two is very unlikely. From my clinical practice, if anaphylaxis is going to happen, it happens fast, it happens within minutes, it will happen within the first hour. But we've compromised here on 2 hours. So if you have a patient who had an immediate reaction within the first 2 hours following the vaccination, and if the reaction was systemic, so whether it was anaphylaxis or urticarial type rash, swelling, but not swelling at the injection site, we allow both urticaria and swelling at the injection site. Even if it's immediate, that's not significant of severe allergic reaction. Somebody who has shortness of breath, somebody who develops that irritant cough, I don't know if you know it, it's the back, once you hear it once, you'll never forget it, is a cough of laryngeal edema, where a patient first tries to swallow hard and then they get this back of the throat cough that they can't stop. Somebody who develops even just rhinoconjunctivitis, but immediately following the first vaccination, first dose, they are to be referred to the hospital setting to see an allergist. However, somebody who develops just a localized swelling or rash just at the injection site, so just at the arm, just around where they were injected, can be vaccinated in any setting, provided that they are observed for 30 minutes following the vaccination. So what about patients who develop a reaction after 2 hours, so delayed reactions? And these are usually skin reactions, so delayed urticaria and angioedema, delayed maculopapular rash, or any other rash. So here, if the reaction is self-limiting, so say, and that's a very common scenario, and I'm sure you've had patients present to you, day 2 or 1 post-vaccination, or even 7 days post-vaccination, the patient wakes up in the morning, starts with a rash, the rash progressively gets worse, and they develop angioedema of the lip or extremities or eye. That's not anaphylaxis, that's delayed urticaria and angioedema. It may or may not be related to the vaccination. It probably is actually, but for these patients, you can pre-medicate them or post-medicate them. So what I advise these patients is they don't even need antihistamine before the injection. I advise them to have the antihistamine after the injection and then have another one on the evening of the injection, and then they continue, depending on when the reaction occurred, depending on which day they develop angioedema and urticaria, they continue twice a day antihistamine for a week or even 10 days. And remember, you can increase that to 4 times a day. So somebody who is already on twice a day fexofenadine, and then on day 3 develops an urticarial skin rash or even itchy skin, they usually know when they start getting these symptoms, can increase the antihistamine to up to 4 times a day. And finally, the last part of the pathway, which I can't see, but hopefully you can, is the delayed type reactions, but these are the more severe type reactions that required hospital consultation or were not easily dealt with by antihistamines. These should also be referred to hospital hub or to see an allergist. So these are examples of first dose reactions. So remember, the immediate urticaria plus minus angioedema and anaphylaxis is red pathway, no more vaccination in the mass vaccination center, revaccination, investigation and revaccination by an allergist in the hospital. So the other types of reactions are delayed urticaria and angioedema. Examples here, we've just spoken about it. Don't worry, use antihistamines up to 4 times a day if necessary. Preempt the event after the vaccination. If you know that somebody is prone to it, they can use it twice a day and up to dose to up to 4 times a day. Fexofenadine does not cross brain-blood barrier, so it's not, in theory, it's non-sedative. What about delayed dermatitis? I'm sure I've seen it. I'm sure some of you have seen it also. So this picture, I have to acknowledge, comes from DermNet New Zealand. They're very generous with their pictures, and they've given me permission previously. I have pictures of patients with post-COVID dermatitis, but I haven't asked their permission. So this is the one I've pulled off the web. So I think what we have to do here is make sure that this flare-up has been completely cleared and the skin is absolutely pristine before we give the next injection of the next dose of either vaccination. I would stick with the same vaccination. So if they used Pfizer, if they had Pfizer, I would go with Pfizer. If they had AstraZeneca, I will encourage that they continue with vaccination. The delayed localized large reaction. So this is the swelling at the injected arm. And here we've actually got some evidence of what happens to these patients, because that's the Kimberly Blumenthal paper. And she looked at the delayed type reactions post Moderna, and what she found is that some patients, in majority of patients, the second dose reaction won't be quite as bad. There are some patients who won't have any reaction, and if you have somebody who does present to you with a delayed type reaction at the injection site, the advice is paracetamol, antihistamines, cold compress. Don't worry about it. It will get better within 7 to 10 days. And finally, delayed small vessel vasculitis. I don't know if any of you have seen it. I have seen it. I'm still thinking what to do with these patients. I'm likely going to switch the vaccination, actually, and likely going to use steroids. That's my plan. But I want to run it past some people. With these patients that are on my books, I haven't revaccinated yet. So we at UCLH, we actually work within the vaccination center. So we, unfortunately, the vaccination center, our hospital vaccination center, is only for staff members and the hospital patients, but it gives me a huge exposure to patients and easy access to the vaccinations. So finally, these are my conclusions. Vaccine allergy is very rare, but not non-existent. It does exist, and it can cause huge immediate problems and delayed problems for patients. The excipient allergy is real allergy. It's exceedingly uncommon. I've been practicing allergy for over 15, 16 years now, and in that time, I've only diagnosed 4 cases of polyethylene glycol allergy. Perhaps, have I missed any? I don't know. I can't be sure, but it is supremely uncommon. Polysorbate AT allergy does exist. I haven't diagnosed a single case. And tromethamol, I've got 1 case of tromethamol allergy, which I've mentioned before. Not all reported anaphylaxis is anaphylaxis. We had a day when 5 patients in our we vaccinated on that day fainted. I had a vasovagal event following their first dose of Pfizer. Most patients can be vaccinated safely. I can't think of a reason why we need to vaccinate a patient, even if they had anaphylaxis to one type of COVID vaccination. I think they should and can be vaccinated safely, provided it's done in the hospital setting. You want to refer these patients, you want to get them investigated, and the reason for it is that it's not like a yellow fever vaccine that you're going to need just once in your life. we are likely to need the third and the fourth booster dose, and you need to have a plan for these patients. And finally, this is my Wesołych I Zdrowych Świąt. My grandma was from Porąbka, from Limanowa, and this is a little tribute to her. So that's the end of that. I'm delighted to take any questions if you have any.
Well, thank you very much, Doctor. It was a fascinating lecture. And speaking from my from what I saw, even in 111, people do call with these delayed reactions. And we just saw a person with delayed localized large reaction a couple of days ago. My colleague saw her, and she ended up on antibiotics because he suspected cellulitis, and probably unnecessarily. And I'll be able to give him a better advice after this lecture. Just before we proceed to questions, I would just like to remind everybody that we will be issuing certificates of attendance that will be something that we could add to our portfolios. And if you would like to receive one, please drop your name and email address in the chat below. Tomek will also, perhaps Tomek, you could also send, put in our contact email there in case somebody would prefer to email us, and we will issue certificates probably next week. So that's just one thing I would like to mention. And in terms of questions, well, perhaps I would like to start with the following. So, I mean, the PEG allergy and this case of this poor guy who died of anaphylactic reaction after a steroid shot, it is pretty thought-provoking. So my question is, so assuming that somebody has immediate allergic reaction to the vaccine, and then we send them to see an allergy specialist, and he or she is diagnosed with PEG allergy, would you then advise them to avoid all medications that contain PEG, which would include things like Movicol? And how would that affect what we practice as GPs?
Okay, so this is the PEG allergy is a minefield, and my least favorite allergen, as you can see. It's very difficult because what you'll then have to do, you have to test them with different molecular weights, PEGs, and you don't just test them, you need to challenge them. And the problem is that it's very risky, because even if you skin test PEG, there have been cases of severe anaphylaxis. And if you look, there's been a paper published recently by the Cambridge group by Schwab Nasa and Pamela Ewan and Priya, can't remember Priya's surname, where they've described skin prick test. So by skin prick test, we mean just putting a droplet of the antigen on your skin, on the forearm, and literally just pricking through it, not with a needle, not with a sharp needle. You do it with a stylet, which is calibrated at 1 millimeter. Okay, it doesn't go into the dermis; it just scratches the epidermis. And this patient had a systemic anaphylaxis. I've seen this before. I've seen it with other agents, but therein lies the problem with PEG. But what you will need to do, you'll then need to do this with all molecular weights of PEG and challenge the patient to see where their threshold is, at what level can they tolerate PEG. It's a hugely laborious work, and one that none of us are looking forward to, and it makes it even more difficult because we don't have a pharmaceutical grade products other than Movicol. So we're always having to compromise, use one product that contains PEG and compare it to another one that doesn't. So we'll use one preparation of hydrocortisone with PEG and another one without. Similarly for polysorbate. It's really tricky, but we should be able to establish that threshold for you. So hopefully the patient won't have to avoid all PEGs, but equally you see patients with PEG allergy who will say, I've always had a problem with shampoos. And when you get them to bring the shampoo, the type of shampoos they reacted to, invariably they all have PEG in them, and it's a molecular weight PEG, and you know that they're allergic to Movicol, and then your job is done. These patients should not have any PEGs.
Okej, dziękuję bardzo pani doktor. Więc może jeżeli ktoś inny miałby jakieś pytania, proszę, jest taka opcja podniesienia ręki na dole ekranu, na tym pasku pod slajdami jest taka zakładka Reactions. Jeżeli na nią klikniemy, tam można podnieść rękę i ja wtedy będę mógł Państwu udzielić głosu. Przypominam, że wszyscy Państwo mają wyłączone mikrofony, więc jeżeli ktoś chciałby zadać pytanie, to proszę też mikrofon włączyć. W lewym dolnym rogu jest ta możliwość.
Mogę się pierwsza zgłosić?
Dorota, proszę.
Ja mam dwa pytania. My bardzo dużo ostatnio szczepimy pacjentów i przy szczepionce Pfizera oczywiście wciąż jeszcze jest rekomendacja, żeby pacjentów zatrzymać na obserwację poprzez 15 minut po szczepieniu. To powoduje, że logistycznie naprawdę jest to trudne do przeprowadzenia, ponieważ mamy często gromadę pacjentów czekających 15 minut, żeby można było ich wypuścić i tutaj przy tym COVID-zie trzeba zachować odległość i jest to trudne. I w tej chwili w zasadzie zalecenia są już takie, że pacjentom, którzy mają jakiekolwiek historię alergii, nie proponujemy Pfizera, tylko proponujemy AstraZenekę. Czy jest jakaś możliwość, żeby te rekomendacje zmienić i po prostu zaniechać tej procedury 15-minutowego obserwowania pacjentów? Czy to jest w ogóle możliwe? Jeszcze mam jedno pytanie. Czy pani doktor uważa, jaka jest pani opinia na temat vaccine safety in view of the fact that we actually don't have any long-term data? To takie dwa pytania chciałam poprosić.
Dziękuję pani Doroto. Co pierwsze pytanie to nie do mnie, do MHRA and Green Book. My też jesteśmy zobligowani trzymania pacjentów przez 15 minut czasami, jak jesteśmy bardzo zajęci, tak jak pani, to pozwalamy pacjentom wyjść po 10 minutach, jeżeli młodzi, zdrowi i szczególnie jeżeli to jest ich druga dawka i nie było problemów z pierwszą. Long-term safety. Ja wiem tyle samo, co wszyscy inni. The studies are not out there yet. We have no idea, no reason why we should expect any major problems. And we have been vaccinating pregnant women and breastfeeding women, and there have been no issues at our end yet. Knock knock. But I don't know. We won't know until these studies come out. So sorry, disappointing.
Rozumiem. Znaczy to pytanie często się pojawia, szczególnie u osób, które się nie chcą szczepić.
Tak.
To w zasadzie ten argument jest przytaczany. My staramy się jak najwięcej pacjentów przekonać, ale już w tej młodszej grupie niestety jest dużo osób, które niechętnie się szczepi i tutaj jest to jednym z argumentów, że tak naprawdę nie wiadomo, jaka jest long-term safety of vaccinations, Pfizer czy AstraZeneca, no ale tego nikt nie wie, bo szczepionki dopiero są właściwie podawane od grudnia, prawda, więc mamy 4 miesiące mamy na razie.
Tak.
Dziękuję pani doktor, dziękuję bardzo.
Dziękuję pani Doroto.
Dziękuję. Martyna, ty proszę. Ty miałaś następne pytanie.
Pani doktor, bardzo dziękuję za wykład, bardzo interesujący. Ja muszę przyznać, może bardziej nie pytanie, tylko chciałam się podzielić swoją historią. Ja miałam wcześniej reakcję anafilaktyczną, szok anafilaktyczny tak naprawdę. W Anglii nie ma tego leku. To był w Polsce podany dożylnie peralgina, metamizol, to chyba tak się nazywa ta substancja czynna. I rzeczywiście miałam podawane adrenalinę, hydrokortyzon, to było bardzo się obawiałam, jeśli chodzi o szczepionkę, natomiast miałam Pfizera i nie było problemu. Mój tato też dzisiaj akurat dostał Pfizera, on miał reakcję anafilaktyczną do anatoksyny po szczepionce na tetanus. Więc też byliśmy troszeczkę, zastanawialiśmy się, czy tata powinien brać to w ogóle w takim małym centrum i muszę powiedzieć, że nie było możliwości, żeby tata miał tą szczepionkę w szpitalu. Ja się obawiałam i pytałam się, czy ewentualnie może być jakiś, no oczywiście anaphylaxis kit na stand-by'u, ale no nie było opcji, że można by było tatę po prostu w szpitalu. A teraz właśnie jak widzę te wytyczne, to widzę, że tata nawet by się chyba nie kwalifikował, bo nie wiem, czy by się kwalifikował ewentualnie do podania dawki w szpitalu?
Tak, bo miał szczepionkę, tak, kwalifikowałby się, bo miał szczepionkę, pani Martyno, reakcję na szczepionkę, pani Martyno. Jeżeli miał reakcję na szczepionkę, to by się kwalifikował na podanie szczepionki w szpitalu, tak, a jak najbardziej.
Aha, no to jednak nie ma, ale na szczęście nic się nie stało, więc bardzo się cieszę,
Tak.
ale wszyscy w całym GP surgery byli bardzo, bardzo zestresowani, podając tacie tę szczepionkę, no ale na szczęście wszystko poszło dobrze. Także no, i też słyszałam kilka innych osób, którzy mówili, że mają silne reakcje alergiczne i mieli Pfizera i nie było problemu, więc to może też czasami kwestia przypadku. Dziękuję.
A pelargina to nie jest NSAID? To nie jest non-steroidal?
Peralgina?
To jest coś innego?
To jest chyba coś innego.
Pelargina to jest non-steroidal, ale on nie
to
jest...
jest non-steroidal, a pani przyjmuje ibuprofen, czy...
Przyjmuję i nigdy nie miałam żadnych
problemów. Okej, no to świetnie.
No, tak, dobrze. Dziękuję ślicznie.
Dziękuję.
Tutaj jest jeszcze jedna ręka podniesiona, doktor Kryńska. Proszę włączyć mikrofon.
Tak, dziękuję bardzo. Just a quick question, really. Presumably there is very little data on other vaccines that are available. Clearly, the Sputnik and the Sinopharm stuff that's come out, and what are the constituents within those? Presumably, we have some idea. Or the other chemicals that are involved in it.
Yeah, possibly. Do you know, that's an interesting question, and I haven't looked it up. I have no idea what's in Sputnik, but that's absolutely.
Not many people do, but apart from the human adenovirus vector, yeah.
I don't know. I don't even know. Is Sputnik mRNA or is it an old-fashioned?
No. It's a human adenovirus. It's a human adenovirus as opposed to a adenovirus.
Yeah. So
so that clearly could have some effects.
So likely in that case, no PEG, but likely polysorbate. Because they will need to put something to emulsify it. They will need to have something that will keep it in suspension.
Yeah, interesting. And clearly that's not going to see the light of day for a while, I presume.
I'll try and look it up.
Yeah.
I've got a very clever pharmacist. He's able to get all sorts of info.
Yeah. Well, it's becoming more and more used in different European countries. I was just wondering about that.
Thank you.
Yeah, thank you.
Dziękujemy. Dr. Schlosser.
Hi, so thank you very much. That was a great talk, very informative. I've got two questions. One relates to two patients I've come across who've developed contrast allergy agents for MRI. And interestingly, both of them developed this during treatment with immune checkpoint therapy for melanoma. So I had to resort to PET scans in one patient. Sadly, that patient has now died. And the second patient, when they went for their next surveillance scan, I went through the recommended protocol, gave prednisolone and I think Piriton 12 hours and an hour or so before, which is what the radiology department said. And actually the patient ended up having the MRI without the contrast. So I was surprised that even following the protocol, they didn't give the contrast agent. But I was just wondering your view on whether the immunotherapy had a role here to play in the MRI contrast allergy. I presume it was the polysorbate that you were mentioning as one of the active ingredients. So that's my first question. So maybe, and then I'll give you the second one if there's time.
Okay. Piotr, hi.
Hi.
We have worked together. Perhaps we haven't worked together. We've met many years ago.
Ah, okay.
Anyway, so contrast MRI. Okay, the first part of the question was, you had 2 patients. Could immunotherapy have influenced things? Yes, absolutely. We know that strange things like immunosuppression will influence, will change your atopic, the patient can change from non-atopic usually to atopic. We also know that if you overstimulate, if you stimulate the immune system, you influence things, you change things. So yes, why not? It was an interesting story that you said you pre-medicated the patient. If the patient had anaphylactic type reaction, pre-medication, no matter how much pre-medication you give, it's not going to work. I advise pre-medication to patients whom I fully investigated. I know that it's very unlikely they have IgE-mediated anaphylaxis, and then you follow this. I think the protocol is called the Greenberg protocol.
That's right. That's what I was told to prescribe. Yeah, correct. Yeah,
that's it exactly. But you can do that. So yes, you can do that. And for people with relatively mild, so non-specific, like somebody who has say just urticaria following an MRI contrast agent, you've investigated, there's no evidence of IgE-mediated reaction, and then you want to do another scan, and you could medicate them, and you will likely prevent another flare-up of urticaria, because the worry is also that if there was an urticaria on the first exposure to the agent, you'll get urticaria, angioedema, and hypotension on the next one. That's the worry, and the pre-med is not going to stop the hypotension, and that's probably why the radiologist sort of chickened out of it.
The first patient actually had, I remember now, actually had genuine anaphylaxis because the radiologist was called urgently, had to give EpiPen to the patient in the scanner. That's right.
Yeah. So, but are you still at Bart's?
Yes, I am. So the reason why I bring the second patient up as well is because he's very keen to have his COVID jab. And I presume then for him, it would be safer to have the Pfizer with the PEG than the AstraZeneca if he reacted to the polysorbate in the MRI.
So
contrast.
I'm not sure there is, Piotr, I'm not sure there is polysorbate there is tromatimol in the MRI contrast agents in some of them.
Okay,
but not,
right.
So, but yes, he would be absolutely safe in theory. He would have his background risk is the risk of the general population with AstraZeneca or with Pfizer. His risk is higher with Moderna because Moderna has tromatimol, which some of the
and also I guess it's a bit of an unknown quantity if the immunotherapy had with the nivolumab ipilimumab has generally affected him with a higher risk of allergies. I guess we won't know that.
I think there is I think it's an interesting area, and somebody should look into it, but it's not an isolated case. So
okay. Do I have time for one more question? I don't know. Okay, so the second question is a drug that I'm using in experimental research. So it's actually has PEG in it, PEG 20. It's a arginine deaminase, which is made from a bacterium. So there's obviously allergy possible to the bacterium, but also a lot of these reactions I think are due to the PEG. And actually the patient, I've had a few that I've continued treating and pre-medicating them with hydrocortisone and Piriton, and that seems to have been fine. So I presume the PEG in the hydrocortisone is of a different molecular weight, and therefore that's why there might not have been any worsening symptoms of the urticaria, etc.
So okay, so here comes the problem. So if you look at the EMC, it's an amazing resource, and if you look at the EMC, if you put any drug and into Google and then you put say paracetamol, EMC, SPC, or just EMC, put paracetamol, EMC, right? It gives you the medicines compendium, and 0.6.1 gives you the 0.1 gives you the active ingredients, so hydrocortisone. 6.1 gives you the list of excipients. And this is very useful because, do you know how many makes there are of hydrocortisone?
No idea.
Neither do I, but there are loads. There's a whole page of hydrocortisones made by Accord and made by other people. And do you know what? They all put different things in them. So there will be a company which will always put a PEG, that's or a company which will tramadol. Or somebody will always want to use polysorbate because that's their recipe and they stick to it and they put in all their drugs. So well worth checking, because the likelihood is what you gave them didn't have PEG in it. The hydrocortisone you used was PEG free.
Great, thank you very much. Super.
But also, Piotr, if you wanted to make it safe, you would go through desensitization protocol rather than pre-medication protocol. So we can talk about it at some stage, or you could talk to Runa Ali.
Okay, yeah. Okay, thank you. Dziękuję.
Okay, dziękuję bardzo. Pani Bożena chyba ma jeszcze pytanie, taki kciuk w górę widzę na pani obrazie.
Bardzo dziękuję. Chciałam się właśnie spytać, well, what's the advisability of giving any vaccine to people with one or more autoimmune conditions? I have two friends that have autoimmune conditions and they are very wary to take any vaccine.
So people with autoimmune conditions, I assume,
rheumatoid arthritis, amongst other things.
Yeah, so by definition, they're in a more vulnerable group, and the advice is absolutely vaccinate. They may not make appropriate antibodies, perhaps, and according to can anyone remember what this recent paper? It was King's, but where did they? It was a King's paper, but where did they publish it? It's to do with, and basically what the paper said, it was actually patients with cancer, but it applies to all the other immunosuppressive autoimmune conditions. And what the paper looked at is the antibody production post the first dose. And what they found, without any doubt, is that cancer patients or people who are immunocompromised do not make appropriate antibodies. So it therefore makes it even more important to vaccinate them, because even though they don't make the same quality or quantity of antibodies that somebody who is fit and well would make, with the first vaccination, they catch up with the second vaccination. So absolutely vital that this type of patients gets vaccinated, definitely.
Is there any preference which vaccine or not?
Do you know what? No preference whatsoever. They much of a muchness. There is something with all of them. They all work. We have a virology center at UCLH that checks the antibodies, both vaccination. They all seem to work very nicely.
Thank you.
Well, thank you very much. And maybe I would have a quick question. At the beginning of your lecture, you mentioned that psychological stress can exacerbate allergic reactions. What's the mechanism behind that?
No. So the psychological stress, can it exacerbate allergic reaction? No, psychological stress can exacerbate spontaneous urticaria and angioedema. Spontaneous urticaria and angioedema is not allergic in nature. Spontaneous urticaria and angioedema is, we don't know the actual pathology of it, but this is a very good differentiator. So this is what I say to patients who come to the clinic and are convinced, absolutely convinced, that they are allergic. So they have these recurrent skin rashes, for several days that migrate from one bit on their leg to another bit, from leg to the abdo, and sometimes they swell up, their lips swell up and their eyelids swell up. And the differentiating question I say to them is, have you ever woken up with these symptoms? Did you go to bed and you were well when you went to bed? You had normal. There was nothing else happening to you. You were completely well when you went to bed. And then did you wake up with symptoms, or did you develop symptoms after waking up, before you even had your cup of coffee? And invariably, most of them will say, yes, that did happen. So this is, it's one way you can try, because you possibly it's 50-50 whether the patients will believe you and you're able to convince them, but you are able to convince them with this differentiating question, so hence, if you've eaten nothing, you've done nothing, you cannot be allergic to, there can't be an allergic cause to your symptoms. Spontaneous urticaria and angioedema, it just is. And it is true that stress will exacerbate it. So, like I said, biological stress of being unwell. So these are the people who go through surgery, nothing happens. In recovery, they will get urticaria and angioedema. The patients who will have a cold, and it's usually in recovery, either they inflame, so get another episode of urticaria and angioedema with a cold, but usually in recovery, they get another flare-up. Patients who will go for an exam or a job interview, and like you said, psychological stress, and end up with a blotchy skin rash. Why this happens, I have no idea, but it does happen. So the trick is to tell them, if you have a job interview, take antihistamine before, take 2 if you have to. You can up it to 4 a day. Fexofenadine is non-sedative. It's safe to take it at 4 tablets a day.
That's a brilliant advice. Thank you very much. Czy ktoś jeszcze miałby jakieś pytanie? Proszę podnieść rękę w górę. Jeżeli nie, to może głos przekażemy Pani Bożenie na koniec tego spotkania. A jeszcze raz przypominam, że jeżeli ktoś chciałby certyfikat, to proszę umieścić swoje dane kontaktowe w czacie. O, widzę jeszcze, doktor Kryńska jeszcze ma pytanie. Poproszę. Pani doktor? Ma Pani wyłączony mikrofon, ja nie jestem w stanie wyłączyć tutaj z mojej strony, włączyć mikrofonu z mojej strony. Musimy poczekać. Pani doktor Kryńska, jeżeli Pani mnie słyszy, musi... O.
Tak, słyszę. Słychać?
Już.
Dobrze,
tak,
dobrze.
Tak.
Coś mi się wyłączyło. Tylko takie pytanie, może troszeczkę z innej beczki, bo jeżeli Pani jest alergologiem, to chciałabym się zapytać na temat insulin allergy z innej beczki, in type 1 diabetes. I nie jest to szczególnie często spotykane, ale nie chodzi mi bardziej o komponenty insuliny jako takiej, ale o samą insulinę i metody leczenia. Jestem pediatrą endokrynologiem i właśnie mam taki przypadek, który będzie szedł do St. Mary's na leczenie. Ale może by Pani coś mogła się podzielić na ten temat.
Tak, świetnie Pani doktor. Tak, alergia na insulinę jest dobrze, istnieje. Pierwszy stopień to jest zrobić odczyny skórne, czyli skin prick testing na różne typy insuliny i czasami jest tak, że, ale ja podejrzewam, że to jeżeli to jest dziecko, to pewnie jest na, jak to się mówi, człowieczej insulinie? Human insulin.
Tak. Nie, zrobione pozytywne.
Więc tak, jak leczymy desensytyzacją. Program desensytyzacji, co to znaczy, zaczynamy od bardzo, bardzo niziutkiej dawki, ale 1 na 10 milionów i co 15 minut podwajamy. To jest proces, który wszyscy alergolodzy mogą przeprowadzić, a potem, jeżeli już dojdziemy do stopnia, w którym do dawki, którą dziecko potrzebuje, przełączamy. Jeżeli dziecko było na injections, jeżeli było na injections, czy było na continuous insulin? Bo oni
nie, multiple daily dose w tej chwili.
Okay, czyli lepiej by było dla tego dziecka, jeżeli było na continuous insulin. jak to się nazywa?
Pump therapy, insulin pump therapy.
Właśnie. To jeżeli dojdziemy do tego momentu, gdzie jest desensitized, to wtedy trzeba
Ale to nie skutkuje we wszystkich przypadkach, prawda? Bo to jest jakiś procent, który reaguje na to desensitization.
Tak.
I wtedy może być problem.
Może być problem, ale ja miałam, to jest rzadko się spotyka, prawda, ale miałam 2 przypadki. Jeden przypadek była nastolatka, którą odczulaliśmy gdzie jest w Gajsie, i drugi przypadek to był starsza osoba, mężczyzna, którego odczuliliśmy u nas w UCLH. W obu przypadkach skutkowało i do tej pory nie słyszałam od żadnego z tych pacjentów, czyli mam nadzieję, że wszystko jest ok. Ma Pani rację, nie zawsze może skutkować i jeżeli nie zaskutkuje za pierwszym razem, to może warto próbować, jaka jest inna metoda. Czy jest coś innego, którą można zaproponować tej osobie?
No właśnie, to jest problem.
Ja bym próbowała,
tak, próbowaliśmy różne
do skutku.
Tak, próbowaliśmy różne insuliny i takie different types, różne tam inne, jak coś mówi.
Ale reakcje są jakie? Anafilaktyczne czy reakcje są skórne?
Nie, reakcje są generalized skin urticaria, kontrolowane w tej chwili tylko i wyłącznie przez antyhistaminę.
Okay. Ale jesteśmy pewni, że to jest reakcja na insulinę, jesteśmy pewni, bo prawda jest taka, że osoba, która ma urticarię, to jeżeli zrobimy jej odczyn na skórę, to one zwykle, te osoby mają bardzo reaktywną skórę i będą reagowały na wszystko, co im nałożymy na skórę, na każdy odczyn.
Nie wszystkie, my też u dzieci robimy skin testing i miało też i controls, i miało inne rzeczy,
nie
tak, i inne reaguje na insulinę, tak. Różne components. Ciekawe, zobaczymy, co będzie dalej.
Ja nie pamiętam, kto jest na pediatrii, tam są dobro.
Nie, to jest nastolatek, do dr Faruki bodajże dostałam.
Okej.
Tak. Dziękuję.
Dziękuję bardzo. Czy ktoś jeszcze miał pytanie? Pani doktor? Nie widzę. Może w takim razie przekażę głos pani Bożenie.
Ja bardzo serdecznie dziękuję. To był wspaniały wykład i naprawdę, no oczywiście tak na czasie, wszyscy na pewno skorzystaliśmy bardzo z tego. Naprawdę dziękuję i cieszę się, że Pani chce się do nas dołączyć i zapraszamy wszystkich na nasze kolejne spotkanie. Znowu na Zoomie. Będzie właśnie 22 kwietnia. W zaproszeniu wszystkie są szczegóły. Zapraszamy wszystkich. Jeszcze raz serdecznie dziękuję za poświęcenie nam czasu na tak ważny temat.
Dziękuję pięknie Pani Bożeno, dziękuję Panie Mateuszu, Panie Tomaszu, Pani Halino i wszystkim bardzo serdecznie dziękuję za uwagę i do usłyszenia, do zobaczenia.